All right. So we are finishing up Unit 3 with Chapter 14, Nervous System Disorders. So we'll try to give you in depth, and I'll try to kind of highlight the need to know stuff to focus on from the study guide and things like that. That's kind of where we'll try to harp a lot on so that you guys have that. Um, but yeah, so we'll get into it. We're gonna finish up here. Um, Unit 3. So we're working our way through this stuff. So chapter 14 is the final chapter. There's 3 chapters, um, a part of unit 3. 17 digestive, 12 cardiac, and then here nervous system. There's a lot of stuff. As I've kept mentioning to you guys in class and in the video lectures, refresh yourself on A&P. You've got to refresh yourself on A&P. Have to. So chapter 14, nervous system, kicking it off. So review of the nervous system. Mainly, you can kind of break up the components of the nervous system into the central system and the peripheral nervous system. Sometimes people refer to central nervous system as CNS and everything in the peripheral as PNS. Central nervous system is easy. It's just the spinal cord down the center of our spine and our brain only. And then peripheral is everything else. It's the cranial nerves, technically nerves 1 through 12, cranial nerves 1 through 12, where they are inside our head and inside our cranium, but they're not necessarily central nervous system neurons. They either have a sensory back and forth or a motor function back and forth. So those are all about, again, sending signals out from the brain, sending signals back to the brain for interpretation. And this is kind of what it looks like anatomy wise. Central nervous system. And then you have, your spinal nerves, your nerves that are part of the periphery, that sort of thing. So it just depends on what the response is of those neurons, but just keep in mind you got a CNS and a PNS. So the brain, there's a lot with the brain. This is the communication and kind of control center. This is where we get process information and turn it into thought or turn it into understanding, decide actions to take. All about maintaining homeostasis is part of our kind of autonomic nervous system, reflexes, those kind of things. But then the brain also does control voluntary actions. So around the brain, we have some protective layers. Around the actual brain itself, we have these layers they call meninges. So layers around the brain are known as meninges. That's where you get the word meningitis, inflammation of the meninges. The meninges are from inside, like they're physically touching the brain to outside. This is the innermost pia mater, arachnoid matter, and dura mater. Those are the 3 layers. And then you have some spaces in between, basically subarachnoid and subdural space. A lot of CSF or our CSF, cerebral spinal fluid, that helps protect our brain, you find in the subarachnoid space. And this is kind of an image to kind of give you that refresher. And you can see that that arachnoid matter there, the layers that kind of divide stuff. And there's really just acts as a barrier for protection. Another component of protection of our brain is and our spinal cord, protection of just the central nervous system is cerebral spinal fluid. You only find this in the central nervous system, or so around the brain, or around the spinal cord. Very similar to plasma, but it's a little bit different. It provides a cushion for the brain so that we take a hit. Our brain doesn't just bounce against our skull. There's a little bit of fluid buffering, but it's highly concentrated with glucose and protein, basically for metabolism and nutrients for neurons. We form it in our brain. We have this structure, really deep interior brain underneath the cerebrum called the choroid plexus, and it's in the ventricles. The ventricles of the brain are these cavities that fill up with CSF and help keep it at flow and let it flow throughout the layers of the meninges down the spinal cord and flow and recycle it as well. And are always flourishing it with glucose molecules and protein molecules. And we try to keep equal amounts of CSF to, again, think of, we don't want extra things in our brain. There's only so much room. We start getting extra things like extra fluid, extra blood that's spilling or leaking from broken blood vessel, then you get little, not enough space to go anywhere, and so the brain is just going to bounce against, come up against the skull, which is an immovable object, and then that can compress the brain tissue and cause issues. This is a big chart that just talks about some of the stuff you find in CSF. Nothing that you have to necessarily know if you're interested. This chart's in the book, and it's a little bit cut off, but this is kind of what you find: protein and glucose concentrations. There's some electrolytes, sodium, potassium for sure, um, but it's a clear, colorless fluid. So, protection of the brain, also besides CSF, we have what's called the blood brain barrier. This is a barrier made up of assistive cells of the nervous system called astrocytes. And astrocytes make this barrier that only allows small molecules through. And kind of controls that balance of any shifting of glucose or proteins that happen. Um, Mainly, it's going to block out big stuff and not let it in. Definitely like toxins, bacteria, um, medications for the most part. There's very little medications that have a structure small enough to be able to go past the blood brain barrier. Um, so it's a good another protection mechanism, basically. So some of the functional areas of the brain are cerebrum, or cerebral hemispheres, two of them, diencephalon, the brainstem, and cerebellum. And this is a great chart for A&P refresh if you guys are trying to think about, because here it talks about frontal lobe, parietal lobe, occipital, and temporal lobe, all part of the cerebrum, the hemispheres, that where we do our thought and cognitive thinking. So you can kind of imagine their function means, so if someone has, a tumor in one of these areas and they're having issues with aphasia and speech and understanding words, maybe that's a tumor or an injury somewhere in their frontal lobe. If they're having issues with their smell, or their hearing, maybe there's an issue happening in their temporal lobe. So you can kind of think of it that way. Cerebellum is hanging on the posterior inferior side of our brain cavity, and that's all focused on coordination, posture, balance. Medulla is part of the brainstem. This is the most inferior portion of our brainstem. It's all about control, coordination. This is the center for vomiting, gag reflex, cough reflex, swallow reflex, and also the control center for heart rate and respiratory rate, that sort of stuff. Hypothalamus and thalamus are more inclined with homeostatic endocrine control. And things like our limbic system is basically the amygdala and the hippocampus. The amygdala and hippocampus are regions that are responsible for emotional and memory. And some of the other areas, again, this is the brain stem. This is the connection between that cerebrum and all the other components to the rest of the body. And it has a few sections. The one we care most about is the medulla oblongata. We talk about that the most, but the midbrain and pons do have a role to play. They're part of the brain stem. Again, cerebellum, dorsal and inferior, kind of to the medulla, dorsal to the pons. It's all about coordination, posture, movement. Basically receives input and visuals, and kind of understands the world around us based on how we move and balance. So the cranial nerves, again, these are technically part of the peripheral nervous system, but we do find them mostly in our cranium, in our head, and that's why they get the cranial nerves. There's 12 pairs. They come from kind of all over different parts of the brain, and the cranial nerves themselves can sometimes, some of them are just sensory only, some of them are just motor only, and sensory means only sensing something and sending them back to the brain, or some of them are motor as well. They could be a mixed nerve where they also elicit function or action, where motor nerves mean that the brain is sending a signal down to an organ or to something to have an action take place. And this is the chart from our book, table 14.3, to summarize all the cranial nerves. I believe you talked about cranial nerves in physical assessment. It's not a big portion of this test. Just throwing it out there is something really, really, really nice to know, that you really want to know these cranial nerves. It was going to come up in physical assessment. It's going to come up in later neurological discussions, but it's not a huge focus on this test. So you're okay if you're still struggling to get these straight. There's an awesome different mnemonics to kind of help remember these. that sort of stuff. So you can kind of think of it that way. This is a great video by one of the guys I really love that does great A&P Secret Science. He's got a nice t-shirt. He's got a sweatshirt on here that's got his logo. And he has a good mnemonic, and he talks about each of the cranial nerves. Spinal cord and spinal nerves, again, still kind of talking about the anatomy of this. The spinal cord is protected by the vertebral column, so all the vertebrae. Basically starts at the medulla oblongata at the base of the brainstem, works its way down all the way through all our vertebrae to the very end. At the very end, that's called a bundle of nerves. That's called the cauda equina. Basically means like horse's tail or tail. Cauda equina is like the tail end of it around, for adults, around L1, L2 area, kind of in between L1 and L2 is where it ends. It's composed of white and gray matter, just like the cerebrum of our brain. And that's just basically different types of central nervous system neurons that are either much more myelinated or much less myelinated with those myelin sheaths around them. And then the spinal cord, again, if you can think about the spinal cord and the nerves that leave the spinal cord nerves, the higher we get up towards the brainstem, so C1 vertebrae, C2, kind of through 5 and 6, all the cervical vertebrae towards the top or around our neck house the nerves that are kind of higher important function. For example, our phrenic nerve kind of comes out around C3 to C5, and that phrenic nerve is responsible for breathing. So this is why someone's so very precautious or so cautionary when someone's in a motor vehicle accident or something where they possibly had a neck injury, and puts them in the C collar, cervical collar, that kind of stabilize their neck, because we don't want more damage happening. Because if we have a fracture around our cervical vertebrae, there's always a potential we're hitting the phrenic nerve, and that nerve controls breathing. It controls our diaphragm, which is the main muscle for breathing. Without the phrenic nerve, we don't breathe on our own. So that's why spinal cord injuries can be very scary, especially the higher up you go. There's a lot of spinal nerves. Again, some of them typically have both pathways, a motor pathway out and a sensory pathway in, by kind of like these roots. A note about reflexes: we have nerves that are dedicated to reflexes around our musculoskeletal system a lot, but we have other reflexes that deal with vomiting and those sort of things. And those are mostly involuntary autonomic, part of the autonomic nervous system. They're involuntary responses to different stimuli, like gagging, vomiting, hitting our certain tendons with the rubber mallet for checking reflexes. That's involuntary. That we're bypassing. Basically, what reflexes do are neurons that bypass the brain. They head to the spinal cord and they come right back out with the motor neuron in an action. And that elicits a response we don't think about. You can't control. Someone hits your tendon around your knee, the most obvious example, your knee is going to kick. You can't think about it. You can't think hard and stop it, right? So that's reflexes, and they allow us to control certain autonomic parts of our body, control our balance better, that sort of stuff. So neurons and conduction of impulses, again, still on the A&P side, just kind of refreshing. Keep in mind that what we're talking, when we say nerves, we're meaning the neurons themselves. I think of neurons as electrical wires, as the electrical highway. They are, right, sending signals like your telephone lines and that sort of stuff. And that's why, especially the central nervous system, definitely requires a decent amount of glucose and protein for metabolism. And that's why CSF is found in the central nervous system components. And they're very highly, neurons are much more about excitability and electricity and fast, rapid communication, faster than muscles. So conduction of impulses kind of follows this path that's similar to muscle contractions, where there's a depolarization that happens and movement of electrolytes like sodium, and that creates what they call an action potential, a potential for that movement to continue along the path of the neuron to get to the next neuron, and then keep that chain moving, basically. And that's how the signal gets passed. So it's a series of depolarization, then repolarizing to a resting state. Myelinated fibers, so what they call myelin sheaths around these cells, around the axons of the neurons, it helps speed up impulse conduction. It helps make conduction more rapid and also protects the neuron. So neurotransmitters. So when two neurons connect, they connect at what they call a synapse. That word up here is synapsis. A synapse is where two neurons are connecting. And that communication, actually, they're not physically even actually touching, but the neurons communicate by chemical messengers called neurotransmitters. And there's some common ones. Some of the big ones you hear about is acetylcholine, dopamine, things like that. Probably dopamine and acetylcholine are some of the biggest ones. But these are the chemical messengers that continue that rapid electrolyte movement to keep that charge going, keep that signal going. And that's how the nervous system communicates. Our endocrine system communicates through blood and hormones. Our nervous system communicates by electrical impulses and chemical messengers, little small molecules called chemical messengers called neurotransmitters. Again, big ones you think of: acetylcholine for a lot of muscle contractions, dopamine for other nervous system impulses, things like that. The autonomic nervous system, and Siebert mentioned in his video, if you watch that, but the autonomic nervous system is our way of controlling homeostasis in the body. That's automatic, and it's a balancing act between these two systems called the sympathetic and the parasympathetic, and they both have motor and sensory interventions that happen. But the sympathetic is more what we call here. The sympathetic is what I always think of as the fight or flight response. So this is your body heart rate, blood pressure, everything ramps up. When you feel like you were just in a near death experience or in a car accident, you kind of feel shaky and jittery and ramped up. That's the fight or flight response. Your body is gearing up for a fight or to run or to in a stressful situation. This is something we use as a protection mechanism and ramps every body system up. And this is just kind of showing that impulse. This is from the book. The other side, this is the autonomic nervous system that's mostly in control, is your parasympathetic. Your parasympathetic is the one that's mostly dominating you every day. I call this one the rest and digest one because it's trying to bring heart rate down, bring blood pressure down, slow things down. And it's trying to kind of counteract. And this is more about digesting food and controlling metabolism and that sort of thing, not the fight or flight. But this is what's in response most of the time is parasympathetic. This is a table from your book that gives a good kind of very detailed about what's going to happen with each part of our body with influence from the sympathetic versus the parasympathetic nervous system. So it's a good little reference, but it's not necessarily need to know for this test. So that kind of moves the anatomy. So moving into like the patho of this chapter and where the focus comes in for the exam is about effects of neurological disorders. So you want to be familiar with these. You kind of need to be somewhat familiar with some of these things. Local, sometimes called focal effects, FOCAL. Focal effects are talking about localized situations, not whole body affected, but local nervous system complications. It's good to keep in mind that predominantly the left and right hemispheres thing is that a lot of stuff, and you saw it with the cranial nerves, you watched that video, like for example, our ocular nerve does like an X shape and actually sends signals. The right eye is sending signals to the left hemisphere and our left eye is sending signals to the right hemisphere. So a lot of our brain is designed in a way to cross over and send opposite signals to opposite hemispheres. And the rationale behind that, I'm not 100% sure. I'd have to do more research, but that's how our brain is set up. And so when we have injuries sometimes affecting the right side, we will see symptoms manifest themselves on the left side of the body. And you see this a lot with stroke patients. A stroke patient has some kind of motor deficit, again, motor function. On the right side injury, they're going to have left-sided weakness or left-sided manifestations. So, know the left and right hemispheres of our brains. Level of consciousness changes is always a neurological dysfunction, motor dysfunction. So walking, sensation, feeling like up to paralysis or paresthesia, tingling, numbness, losing vision loss, losing visual fields, any trouble understanding or speaking languages, and severe cases, seizures, that sort of stuff. So local effects, again, are more in the area of numbness or paralysis to like the right arm, something very specific area is caused by something very specific, a specific lesion in a certain region. Again, left and right hemispheres means that there's crosstalk or cross signaling between everything. But just as a rule of thumb, our left hemisphere is much more logical, analytical thought processes. Our right hemisphere deals with cognitive thought around like art and music and behavior and emotion, that sort of like relationships, that sort of metaphysical kind of thought. um, Level of consciousness, you've talked about this probably in physical assessment class, but overall this is a good tool to kind of keep up with any changes in neurological status, to establish a baseline with somebody. Some patients are baseline confused. So, but you can tell when they change if you have to assess that. So typically it goes as alert and oriented times 4, and that's to person, place, time, situation. So if I walk in a room and I'm trying to assess someone's orientation and how alert they are, obviously if they're talking to me and awake, they're alert. I would ask them some questions and start somewhat specific and get broader and bigger if they're having trouble. So, for example, ask them who they are, what's their date of birth. If they know that, they are oriented to themselves, to person. If I ask them, hey, where are you right now? And they say, I'm in the hospital. You say, okay, you know place. I say, what time is it? Well, time is, it can be a little bit hard sometimes in a hospital setting because you got no windows in a lot of those rooms. And, it's hard. So you could say, do you know what month it is, what day it is? If they know what day it is and what month it is, they're completely oriented. If they're a little fuzzy on the month, maybe try to make it a little more general. Do you know what year it is? They're a little fuzzy on that, make it a little bit more broad. Do you know who the president is? For someone that is elderly that lives in a long-term care, if they know who the president is, but they thought it was February for a minute and then they said it was March, you know, whatever. I would still say they're oriented to time. If they say the president's Ronald Reagan, well, okay, they're not oriented to time, right? So there's a subjective nature to this, and then situation is, do they know why they're here? So I'm in the hospital because I fell and broke my hip. Okay, that's the situation. They're aware of the timeline of the situation. So that covers a lot of stuff. But it can be subjective, and you want to kind of start fully specific with your question and let them get more broad to kind of see where they're at. Again, if they have no idea about their situation, time, or who they are, and they're not responding, they're not alert and oriented at all. They're, another condition entirely. But again, this kind of helps us assess changes. Motor function. Motor neurons control voluntary movement and involuntary. So if there's loss in voluntary or involuntary movement, we'd be worried about what motor neurons are damaged. Typically, you see this a lot with some brain conditions, but a lot of times you'll see this with things like spinal cord injuries and those sort of things. This last part, this is not need to know, but if you just were curious, decretate and decerebrate, or decretate and decerebrate are basically a posturing, a movement of the body that's abnormal and really signifies severe brain injury. It's basically an abnormal flexion of the arms and wrist. And decerebrate is more like a hyperextension of extremities. It's a very odd, but it indicates brain damage. Sensory deficits. Most of our sensations for touch and feel go to our parietal lobe. So typically, if we're having touch and feel issues, you would kind of worry about one of the parietal lobes of the cerebrum being affected by whatever the condition is. Visual loss too. Visual loss is known as hemanopia. I always think of the opias as like optic. So all of the conditions that are associated with eyesight, like I'm nearsighted, so that's myopia. It's all like opias, opias. So you can hemanopia is visual changes or loss to vision. And that could be optic nerve issues. And this is just showing you kind of that right hemisphere again, that a lot of our nerves do a crossover and go to the other hemisphere to send their information. So here's one of the kind of first highlights of the need to know aphasia. So changes in language is anytime a patient has any change in their language, you go with aphasia. Aphasia just means a general inability to properly understand or speak language that they used to be able to. This would be a frank change, and you can see this after strokes and other brain injuries. Aphasia has kind of three subcategories. It can either be receptive, which means it's damage to their Wernicke's area, but receptive basically means they have inability to understand language. Expressive aphasia, basically damage to their Broca's area. It damage or expressive aphasia means they can't express themselves. They can understand what you're saying, but they can't hardly speak effectively, and they can't get their thoughts out in language anymore. And mixed would be, or they usually call it mixed or global aphasia, is damage to kind of both these areas and these nerves. And so they have issues receiving. They have issues with receptive and expressive aphasia. Dysarthria is like motor dysfunction in the muscles. So kind of a motor neuron dysfunction with the muscles around the mouth and the tongue around speaking. A little bit less common, but definitely know what aphasia is. And this is a nice chart that's in your book or table 1416 that talks about the different types of aphasia. You want to know the different types of aphasia. You need to know the different types of aphasia. Need to know. So there's some other language disorders that are interesting. The dysarthria, agraphia, alexia. Probably the most common one that I've seen, anecdotally speaking, is agnosia. Agnosia is like loss of recognition or association, in a way of like, if I handed you a coffee mug right now, you would know, well, I put coffee or I put a liquid in it. But if someone's suffering from agnosia, I may hand them a coffee cup and they don't know what to do with it. They don't have a recognition or association with a coffee cup and coffee or drinking liquid, right? They just lost that connection, even though that's been established for them. So seizures are one of the stuff that's on the study guide. Seizures are need to know, what are seizures? Well, seizures are also kind of known as convulsions, but there's spontaneous, basically excessive firing of neurons that causes the tremors and the shakiness and sometimes the loss of consciousness and the full on, like you see in the movie, someone falls down, they're not responding, and they're just shaking on the floor. You call that convulsions. That's a seizure. But there's different types of seizures. What causes them? Seizures can be a secondary effect for a lot of things: swelling or bleeding down the brain that cause increased intracranial pressure, loss of oxygen, actually hypoxia, inflammation on nerves, inflammation around the meninges of the brain, such as conditions talk about in a minute, like meningitis. There's a lot of conditions that can lead to seizures if they're left untreated, especially hypoglycemia. Super low glucose levels, hypoglycemia, will lead to seizures as well. So there's a lot of things that could cause them. There's several different types. You don't want to hone in on too much the different types. I'll give you kind of an idea, but one thing you do want to kind of hone in on is this idea here, is that people that suffer from seizures often have this weird manifestation they call an aura before they have a seizure. Sometimes that shows himself as like weird involuntary repetitive movements, almost like a tick, or similar to like Tourette's, like this tick that happens. Or it can be this aura, this abnormal sensations. And they also call aura like prodromal period, but you want to know what aura is. Aura is something that can help people that suffer from seizures have a prediction when they're going to have one. It depends on what part of the brain's affected, but sometimes people, they describe an aura as sensory changes. So changes in like visual disturbances or hallucinations, sometimes neuromotor, like numbness, tingling, sometimes a feeling of like confusion slash deja vu or memory confusion. It's very interesting. There's different types of seizures. I think the biggest one to highlight is what they call here the tonic clonic. Tonic clonic is known as a grand mal seizure. Tonic clonic is grand mal, grand, Grand, mal, MAL seizure. That's the one you see in the movies, and the big one that everyone thinks about when they think of a seizure. Usually this is characterized by the loss of consciousness and the falling down, and then the muscle stiffness, loss of control, the involuntary jerky body movements all over. They could lose bladder control as well during these seizures. So it's pretty frank and scary. You see one in person, but that's a tonic-clonic, or also known as a grand mal seizure. That's probably the biggest one to highlight. There's definitely some other ones: the petit le mal, myoclonic, simple partial, complex partial. It gets a little bit confusing in the weeds. So I would just highlight the tonic-clonic, and that's also called a grand mal. And the no with seizures, especially something like a tonic-clonic, where they lose consciousness. Usually, there's a period after seizures, and this is neat to know. The period after seizures they usually call postictal period. So postictal state, I call it like a postictal state, is a state of confusion, disorientation. Usually there's fatigue or weakness associated with seizures, especially like the tonic-clonic grand mal seizures. They're going to have a postictal state, and there's not really any treatment for postictal. It's just to kind of wait and see and let brain function return and just give them time and let everything come back to them. But the problem is, if seizures continue to happen, status epilepticus is continued seizures over and over again. Eventually, it's going to cause damage to the neurons in the brain, and it's going to cause brain damage and deprive the brain of glucose and oxygen, because its demand goes up, because it's just constantly neurons just firing. Can be life threatening. So if kind of highlights from seizures: what is a seizure? There's several types of seizures, but the one we see in the movies is the grand mal, tonic-clonic. And a lot of times before a seizure, they may have an aura, a weird sensation of deja vu, sensory changes, weird vision, weird smells, that sort of stuff. And then a lot of times, if they have a seizure that causes loss of consciousness, they'll be in a postictal state afterwards. That's confusion, disorientation, that sort of thing. Increase intracranial pressure. Mainly, this talks about anything that kind of increases pressure in the brain. And there's a lot of things, but just think about the fact that it's our brain case. Our skull is a case that develops or envelops our brain. And so if you put any more fluid than that's already in our brain, where's it going to go? Well, it's not going to move our skull any. Our skull is fissured together. All the plates of our skull are tight and packed, and the bone is hard as any metal. Okay. And so bone is not going to give. So what's going to give? Your brain tissue is going to get compressed by this fluid buildup. And so if it's excess fluid, what they call cerebral edema from huge fluid shifts, or if it's blood from a bleeding stroke, excess cerebral spinal fluid, it's going to compress the brain. So we have to kind of treat that. They have treatment methods that talk about boreholes and actually accessing the skull and letting out the pressure to try and relieve the pressure, and then treat the underlying cause. Usually, intracranial pressure is not a disease on itself. It's a secondary cause to some other disease process that we need to figure out. We treat the disease process. In the meantime, try to keep the pressure off the brain so it doesn't cause permanent damage to the brain tissue. And this could also be from a tumor, because even a benign tumor is going to take up a lot of mass in our brain, and that's going to cause problems and symptoms. And this talks about the effects of intracranial pressure. Not necessarily need to know, but just interesting to know it is. Diagnostic tests associated with our nervous system. There's a lot, but the gold standards usually go down to CT scans, MRIs. MRIs are the best imaging we can get, but they're expensive and they're time consuming. It just depends. You can do Doppler studies. They can do angiography, which is injecting dye into the vasculature around your brain. Another big one is a lumbar puncture. That's usually to check cerebral spinal fluid and make sure there's nothing in there that shouldn't be. CSF, cerebral spinal fluid, should be sterile, and there should be high levels of glucose and protein in it, but not much else. So obviously, if I take a sample of someone's cerebral spinal fluid and there's bacteria in it, alarm bells, right? It should be sterile. So that's called a lumbar puncture. We can do that. It tells us a lot about some neurological disorders. Other acute neurological problems, brain tumors, kind of mentioned that, vascular disorders, infections, brain injuries, and spinal cord injuries. Brain tumors, again, it depends. They're usually invasive and hard to treat. They're difficult to remove. And because of the blood-brain barrier, chemotherapy drugs, medications typically can't really treat a lot of brain cancers. So we have to either do surgery or chemotherapy. And it's just a matter of time before that tumor is going to take up enough space that causes increase in intracranial pressure and brain trauma. So vascular disorders, mainly talking about TIAs and CVAs, but also mentioning aneurysms. We've talked about aneurysms before. But the main point for this, the need to know here is just differentiating. You need to know the difference between a TIA and a CVA. So TIA stands for transient ischemic attack, and CVA stands for cerebrovascular attack. Um, Basically, that you can break these down, especially the CVAs, just into two types. You can break them down into hemorrhagic or ischemic. So when someone has a stroke, it means that either a blood vessel ruptures and they have bleeding on their brain. That'd be a hemorrhagic stroke. Very big deal, very big emergency. All strokes are emergencies, but that one's bigger. And then there's ischemic, which is very, very similar to the process that happens or we undergo in a heart attack situation. Loss of oxygenation to certain parts of the brain causes cell death and injury. That's ischemic strokes. There's only two types. And it's going to interfere. Again, symptoms probably will vary with strokes or TIAs based on the part of the brain or where that artery is that's affecting and what part of the brain it is. So TIAs, transient ischemic attacks, may occur just kind of one off. Sometimes they happen kind of in a series, like bam, bam, bam. It's the key to the TIAs is a temporary localized reduction of blood flow to the brain. So why would this happen? It could be a vascular spasm or sometimes a vascular spasm related to atherosclerosis, the fatty cholesterol plaques that develop on the wall of an artery causing diminished blood flow. And, you have a minute where you get stressed or you have a heightened oxygen demand to your brain. And then all of a sudden there's just not enough blood flow because of the sluggish flow through there anyway. And then you get symptoms of a stroke. The symptoms of a TIA and stroke are the same, but TIA is the difference is temporary and the symptoms resolve. And that's why you would call it you would call it a TIA over a stroke because there's no permanent damage. The symptoms resolve and blood flow gets reestablished. But what TIAs tell us is a prelude, basically, a prelude to eventually having a CVA potentially if we don't do corrective action, blood pressure control, medications, lifestyle changes, things to correct the problems that might be causing us to develop TIAs. So it's a partial occlusion. Again, could be vascular spasm, could be a small, tiny embolus. It could be atherosclerosis, but the symptoms are kind of the same. It depends on where the ischemia is, but they're usually, again, kind of waxing and waning, intermittent symptoms like muscle weakness, facial droop, numbness on the face. Could be some aphasia, the loss of communication ability. And again, repeated TIAs is basically kind of alarm bells that we're about to have a massive stroke somewhere because we have multiple areas of atherosclerosis development. So CVA stands for cerebral vascular accident, and which is known as a stroke. And that is the same as a heart attack, just of the brain, basically. It is an infarction. So death due to ischemia of brain tissue. And again, it could be a ruptured blood vessel that's hemorrhagic, or it could be occlusion to a blood vessel, a total occlusion to a blood vessel, which is like an MI, and that would be ischemic. The biggest thing with CVAs is time. That's the biggest thing. A lot of hospitals, you'll notice that are their stroke certified facilities, they're all about time to scans and time to labs and time to assess if someone did in fact have a TI versus stroke. Because if they have a stroke, there are some medications, some things we can do to try to limit damage to the brain. But really, from the time the symptoms start, they've saying there's really only like 30 minutes. It only takes 5 minutes of total ischemia to cause brain damage. So, in time is of the essence with CVAs. We want to maintain as much function as we can. But again, the types of CVAs are going to be related to a thrombus, which is atherosclerosis, an embolus, which is a breaking off of that clot, which would be atherosclerosis, arteriosclerosis, plus coming from somewhere in the heart, maybe coming from a different area in the body. And then they're going to be probably hypertensive related, which could be a hemorrhagic stroke, but could also be ischemic. But typically, hypertension related is going to be the one that causes ruptured blood vessels. Could you guess who the patients are that are more at risk for CVAs? The same old, same old. The people that have had an MI before, because we already established they have a large amount of arterial and atherosclerosis, diabetes, hypertension. It's kind of same for everybody. Again, MRI can kind of determine the cause of the stroke based on kind of location and what happened. MRI is the kind of golden diagnostic tool for strokes, but we can do CT scans because they'll show us bleeding or they'll show us frank injuries right off the bat. And again, it depends on the location, but the signs and symptoms are basically very similar for strokes or TIAs. The face kind of acronym. Someone will have facial drooping. So if I were to smile and one side of my face is drooping, facial paralysis, flaccid muscles, that's one. Aphasia is the other, kind of inability to talk or communicate effectively. And then slurred speech is another one. So speech and aphasia together. And then arm drift is another. Arm drift is excuse me, is if I were to lift my arms up and hold them up, one of my arms would start to drift. This can be assessed pretty quickly. On the other side of this, too, cerebral aneurysms, very similar, but really what they are is there's an artery that has an aneurysm. Remember, an aneurysm is an artery wall kind of ballooning out. And so if an aneurysm develops, typically somewhere around the circle of Willis, this circular structure of blood vessels coming in from the brainstem, it could be a slow bleed, and they may not know anything until they have a headache and they get increased intracranial pressure and then death. So they can be very scary because there may not be symptoms immediately, but they may have pressure on their visual ocular nerve, what's called nuchal or knuckle rigidity. This is related to basically the neck. When I flex my neck, having stiff neck and pain when I do that, vomiting, seizures, that sort of stuff. So infections. So meningitis, you gotta need to know meningitis. Usually meningitis is bacterial origin. It can be viral. Meningitis can be viral, and viral is usually less significant and usually resolves on its own. But with bacterial, it's very dangerous, and early diagnosis is kind of the key for bacterial meningitis. Basically, the patho behind meningitis, remember the meninges are the layers of the brain and spinal cord. So meningitis, itis, is inflammation and infection of the meninges of the brain and spinal cord. So typically, if I already have a blood infection, I'm already septic, that's more risk for it to cross over that blood-brain barrier. It's always possible. A nearby tissue injury or infection. So I already have a scalp infection. I have an infection around my back. I had back surgery and then I get an infection to the back surgery wound. That's proximity to the spinal cord. And then direct access is talking about if someone had a spinal tap or a lumbar puncture for anesthesia, for like an epidural, for lumbar, any kind of, that's always a potential vector for stuff to get into the cerebral spinal fluid and the central nervous system. And this inflammation basically leads to increased swelling and blood shifting and fluid shifting, which increases the intracranial pressure and affects blood vessels as well. This is some of the etiology. This is not necessarily need to know. This is just talking about some of the common organisms. The one thing to note is that our neonates, remember, don't have the most developed blood-brain barrier. So it very common bacteria like E. coli could potentially cause meningitis in a newborn or neonates, usually, premature babies. Signs and symptoms, usually sudden onset with the bacterial meningitis, severe headache, photophobia, that nuchal or knuckle rigidity, which is basically the nuchal rigidity is the rigidity of the neck. So I tilt my head down, I tilt my head back, I twist my neck. The movement of the neck is very painful and very stiff. Koenig and or Brudzinski signs. Koenig sign is about the patient's inability to kind of extend their knee due to the meningitis. And then Brudzinski sign or Brudzinski's test is basically the patient lies on their flat on their back, and the person examining them is going to try to lift their head, like flex their neck and chin towards their chest. Uh, and when they do that chin to chest, if their hips and knees respond to this neck flexion, then that's Burdinsky's sign. Also, besides the nuchal rigidity is the big one. Um, Severe headache, nuchal rigidity, vomiting, lethargy, fever, chills, could lead to seizures, coma, that sort of stuff. The thing to know about this too is that bacterial meningitis can be produced as like airborne droplet. So they're on droplet precautions. It can be spread by mucous membrane saliva droplets. So people have to wear surgical masks. The patient needs to wear a mask when they're transported. Private room, if we can, for sure. Typically, with it needs to be IV antibiotics as fast as we can. You can treat them with some steroids. Um, and watch for signs of increased intracranial pressure or seizures. You do not want to wait around for a lab test. We'll test a lumbar puncture. We'll test their cerebral spinal fluid because in bacterial meningitis, CSF is going to have the bacteria in it. But most of the time with bacterial meningitis, it's so serious that they don't even wait. If they suspect it at all, if they have the Burdinsky sign and the nuchal rigidity and any reason they could have meningitis, they go straight to doing IV antibiotics and wait before they even have the test. They don't wait. But after the test, of course, we could change antibiotics if we need to. Encephalitis is infection of the brain and spinal cord. It may include meningitis as well. This is definitely can be viral in nature. Some other infections that are more neurological related, just as nice, need to know, is tetanus, Clostridium tetani. We've all had a tetanus shot, but tetanus makes spores that can live in soil. And so they can tend to get into an open wound and they have a toxin that affects the nervous system. The big thing with this is that jaw stiffness, call it lockjaw. Tetanus causes lockjaw. And that typically is the main symptom that swarms for that. Polymyelitis is basically poliomyelitis is polio, is a viral infection that's still common in West and Central Africa, somewhat eradicated in Western countries, but it's droplet or direct contact, and it fever, stiff neck, vomiting, loss, eventually paralysis or loss of lower extremity function. Another virus, herpes zoster, is shingles. Herpes zoster is also the virus of chickenpox. But as we get older, it stays dormant in dermatomes. It stays dormant, or excuse me, it stays dormant in some of our nerves and then pops up later in life, causing lesions that are painful and blistery and irritating and rash. Guillain-Barré. So Guillain-Barré is a need to know. Guillain-Barré is a syndrome basically around post-infection, like polyneuritis, inflammatory. It's an inflammatory condition of the peripheral nervous system. So Guillain-Barré focuses on the peripheral nervous system. It's usually a weird, basically systematic peripheral nervous system inflammation response to a previous infection. And it messes with myelination and the white blood cells around the nervous system and basically impairs nerve conduction. So they're going to have paralysis or progressing weakness of the arms and some of the respiratory muscles. So the big sign with Guillain-Barré is this progressive muscle weakness. Other brain injuries, skull fractures, that sort of stuff. Concussions. Concussions is one of the most common brain injuries that you see. But we worry about brain swelling. So yeah, concussion, very minimal, but this is the most common type of brain injury you see. And there's some swelling involved, and that's where it can cause severe symptoms. Some of these other ones, self-explanatory, I think. Again, not going to take too much time with this, but again, direct injuries, like physically injured, secondary are like edema, bleeding, that sort of stuff. But all of it's going to kind of cause trauma to the brain tissue, and that could cause brain cell death. The neurons in the brain do not regenerate very well or at all. And so injury to cells in the brain is going to lead to some permanent loss. And so there's some hematomas. Hematomas are just bruising and broken blood vessels in certain areas of the brain, and they usually could get reabsorbed, but sometimes they cause a lot of damage. Again, local pressure is the problem with hematomas. could lead to seizures. Just signs of increased intracranial pressure is more common. Spinal cord injury, keep in mind again that results from fracture of the vertebrae. And when spinal nerves are affected, it's going to compress those nerves and it's going to cause, temporary or permanent paralysis or loss of function. Um, and that could depends on the injury, like how severe the fracture was. Um, Tetraplegia, paraplegia, those are just common words. Tetraplegia is also known as quadriplegia. That's paralysis of all four extremities. Paraplegia is lower. Usually, the lower extremities are numb based on where the injury was. I mean, the common complications you associate with quadriplegia and paraplegia is contractures, muscle spasms, development of decubitus ulcers, so pressure ulcers. Respiratory urinary infections are common, and then urinary retention or constipation. Autonomic dysreflexia is a unique one, but it's a sympathetic nervous system response. So it messes with our hormone production, causes a lot of increases in blood pressure and tachycardia. That's more of a secondary condition sometimes. Again, complications of spinal cord injuries go to skin breakdown, pneumonia, infections, ulcers, that sort of stuff. Hydrocephalus, spina bifida. Hydrocephalus is excess CSF. We're generating too much for some reason within the skull, and there's just nowhere for it to go. This is something that's very more common in babies. Um, Again, abnormal production of CSF or tumors causing CFS production. Spina bifida is a neural tube defect. Usually genetic and environmental factors are related, but they're basically the central nervous system. The spinal cord tube has a irregular structure to it where there's a pocket or there's nerve damage that are rolled up into the pocket. It creates this big balloon on the back that needs to kind of be treated, and it just depends on what type of spina bifida it is and what they can do for it. Cerebral palsy is a disorder, is a group of disorders. Basically, there's just abnormal functional areas in the brain. This usually is related to some viral infections, that sort of stuff. It can cause some transient brain damage. There's not one factor, usually multiple. It could be related to ischemia or brain damage, but a lot of times it's related to viral infections and or long-term infections. Some chronic degenerative disorders, so chronic, slowing or generation of the nerve endings. There's multiple sclerosis, Parkinson's, amyotrophic lateral sclerosis, myasthenia gravis, Huntington's disease. I'm just going to highlight a few. One need to know is MS, multiple sclerosis. This is progressive demyelination of the neurons in the brain and the spinal cord. So basically, the myelin that protects those nerves not only protects them, but increases their impulse conduction. So if that gets torn away by multiple sclerosis, then the impulse conduction of neurons slows. So everything gets sluggish. There's a few different types, but overall, the theme is the same with MS. It's sluggish. Okay. Has usually a younger person onset. There's not exact known etiology, but is autoimmune in origin and maybe genetic as well. And typically it's you're going to have weakness, vision changes, numbness, tingling, just progressing weakness and paralysis that will start in the lower extremities and extend to the upper extremities. And then usually there's a loss of sexual function, bladder and bowel coordination, and there's fatigue associated with it. Parkinson's is a need to know as well. Parkinson's disease is a progressive degenerative disorder. Basically what they call the extra pyramidal motor system. But basically with Parkinson's, there's an imbalance basically between what they call the basal nuclei, this portion of the brain, that causes this excessive neuron firing that messes with our motor function basically. And so Parkinson's can be idiopathic or primary, but it can also be secondary to other diseases. That's so much the manifestations, I think, is the thing. Parkinson's manifestations, not on this slide, are pretty much the same for most cases of Parkinson's, but they're tremors, so shaking of extremities, tremors at rest, um, muscle stiffness, poor, terrible balance, and a shuffling gait, which means their walk gait is their way they walk, very shuffling, that sort of thing. ALS is also known as Lou Gehrig's disease. There's no identifiable cause, so etiology is as idiopathic. It's a progressive disease, usually affecting motor neurons, um, and some cognitive impairment. Myasthenia gravis is another autoimmune disorder where actually there's antibodies that are generated affecting one of the neurotransmitters, acetylcholine. That acetylcholine neurotransmitter is mostly involved in muscular contraction, especially skeletal muscles. So facial and skeletal muscles become weak, and there's usually dysphagia and aspiration risks with myasthenia gravis. So progressive muscle weakness of the face and extremities. Um, Huntington's is an inherited autosomal dominant. It usually doesn't manifest till someone gets a little bit older. It causes basically atrophy of the brain and the frontal cortex. And it causes kind of diminished everything. Dementia is a progressive chronic disease of just cognitive impairment. There's memory loss and confusion associated with it. There's types of dementia, vascular dementia. There's some that are related to infections and other genetic components. And then Alzheimer's disease is a similar family to dementia. It just causes these tangles or these plaques around neurons that mess with the ability of the mess with the ability of the neurological transmission, basically. And again, it's still a lot of research on that, but it's eventually a death sentence, unfortunately. So yeah, that is everything with neuro. It's a lot. Hope you guys enjoyed the video lecture. Hope if you have any questions, please let me know. Yeah, you guys take it easy and have a great evening.